Welcome to Medicine Handy Points. Our topic for today's discussion is gastrointestinal bleeding workup. So we will be briefly discussing few features of investigation. So let's begin. Now, gastrointestinal bleeding can be obscure. So in obscure is usually detected by fecal occult blood test, or it could be in form of fresh blood, which could be visible to naked eyes. It could be black stool in form of melena, or it could be vomiting in form of hematemesis. Now, so let's approach how we will go forward when we see blood from the GI tract and how we will investigate it. Gastrointestinal bleeding workup starts by doing endoscopy and colonoscopy. We will not touch on the basic investigation like CBC, PT, population profile, stuff like that. We will be touching the major things in the workup for GI bleeding. So we will do endoscopy and colonoscopy. If they are negative, we have to repeat them again because there are high chances of missing the target. So we can repeat them again, but for the third time, we cannot repeat them. So for the third time, we will not be going for endoscopy and colonoscopy again. In fact, we will proceed to capsule endoscopy. So if the capsule endoscopy shows a suspicious lesion for bleeding, so that could be the source of bleeding. So we'll go for push enteroscopy, which is a technique in which endoscope is pushed into the small gut to find the lesion. If still no cause found, we can then do angiography or RBC scan, red blood cell scan. Angiography can detect bleed up to 1 to 1.5 ml per minute. This is the bleed which they can detect. Means a small bleed can be detected by angiography, while the RBC scan can detect bleed up to zero point 0.1 ml to zero point 0.5 ml per minute. So RBC scan can detect a very small bleed uh, as well. So we can do either angiography or RBC scan, depends upon local protocols and availability of the resources, because these two procedure can detect very small bleeds. Now, in GI bleed with no hemodynamic compromise, like with normal BP, endoscopy should be done within 24 hours. But in case of low BP or hemodynamic compromise, we have to do the endoscopy immediately, but after the initial resuscitation, which we include IV fluids, large bore cannulas, blood grouping, stuff like that. Now, in lower GI bleed, where there is a massive bleed, you can do colonoscopy because this massive bleed coming on and you cannot see anything in the scope. So the best is to do angiography with the target to embolize the bleeding vessels. So this is how you manage it. Thank you for watching. I hope you like the video and please subscribe to the channel.